Today's session is about sleep and PWS and will be separated into two parts. First, a short presentation by Dr. Erin Chidekel around sleep and PWS, specifically the science and symptom recognition. Second, we'll have a conversation with Cindy Szapacs, a caregiver to a teenage son with a PWS, and in addition to PWS, also has a diagnosis of narcolepsy and a neurological sleep disorder. So without further ado, let's welcome Dr. Chidekel.
Thank you very much. It's a pleasure to be here. As a pediatric sleep medicine provider, my perspective will be somewhat child-focused, but sleep is certainly a lifelong initiative and is something that we all require and enjoy when we're able to get it. Supposed to say I have no conflicts of interest to declare, so that's done. I start all of my sleep lectures with this picture of Calvin. And the reason I like this picture is because you can't really tell at first glance whether he's yawning or having a temper tantrum. And when we think about sleep and how it regulates who and what we are, the linkage between sleep and function is absolutely top of mind. So each of the domains that you can see on the slide here, emotional, cognitive, behavioral, with respect to performance, all of those things are integrally linked to good, healthy sleep. And then good, healthy sleep obviously is important to family dynamics. And then we'll talk about the influence on health as well. Now, specific to PWS, it's well known that infants and children with PWS are at increased risk for both respiratory and non-respiratory sleep disorders. I'm a pulmonary medicine physician by training, but in our sleep medicine practice, we care for both respiratory, those sleep disorders that have to do with breathing, and non-respiratory sleep disorders. So we'll talk about the domains of behavioral sleep problems and then problems related to excessive sleepiness. Now, these are very, very common among people with PWS, and epidemiological data are somewhat difficult to get, and they're never perfect, but some of the themes are really important. And so up to 80% of children with PWS can have obstructive sleep apnea, and I'll define that for you later in the presentation. And then the non-respiratory sleep disorders, which again, as I mentioned, can be categorized as disorders related to excessive sleepiness, are extremely common as well. So up to 100 children in some surveys, not all surveys, of children with PWS have abnormal sleepiness. And up to as many as 30 to 40% of people across all ages with PWS have a form of narcolepsy. And we'll come back to that as well. When people of all ages have developmental differences, there are issues related to the timing of sleep, and then issues related to the neurocognitive, behavioral, and social aspects of sleep as well. Now, these sleep-related concerns certainly evolve across childhood. Sleep looks very different in an infant than in a toddler, and very different in a toddler than an adolescent, and very different in an adolescent as in an adult. But I would encourage you throughout the presentation to think about the importance of sleep to overall health and how it really is something that should be part of the discussion about health across the lifespan. So this is a picture of my young son, who's all grown up now, asleep. And when we think about normal sleep, a practical definition could include a reversible state of perceptual disengagement from and unresponsiveness to the environment. And boy, that's a lot of complicated words. But basically, when we go to sleep, we wake up and we can be awakened. So sleep is different than anesthesia. It's different than coma. And we're disengaged and relatively unresponsive to the environment. But clearly, if something is loud enough or dangerous enough or light enough or noisy enough, it's going to raise our attention and it will awaken us. When we think about sleep, it's usually or should occur in a lying down, safe position when sleep is planned. So when we talk about excessive sleepiness, sleep attacks and sleeping at unusual times or in unusual positions is one of the, or some of the questions that we ask about. So none of us should be falling asleep behind the wheel. None of us should be falling asleep while we're eating dinner. We should be asleep in our beds. And sleep should be peaceful. And so people with sleep apnea or sleep disordered breathing, if the sleep is disrupted and restless, that could be a sign of a sleep disorder as well. Now, when we think about sleep as a system, there are two important things to think about. The first is the biological clock or the circadian system. And the second is the sleep drive, which has a fancier name, the homeostatic system, but it's really just the sleep drive. And so to dig into these a little bit more, the circadian system is basically, as I mentioned, it's the biological clock. Circadian rhythms exist in all living things. The easiest example is daylilies, which close at night and open up in the morning. And so the sleep-wake cycle is really just one example of a circadian rhythm that is so common throughout nature. The other thing that's important is that the circadian clock is located in the brain, and there are brain cells in the suprachiasmatic nucleus, fancy name for a structure where these brain cells live. And these neurons or brain cells intrinsically, mean automatically, generate a rhythm via genes, clock genes, that result in different gene products that govern wakefulness and sleep. So why is it important for me to tell you about clock genes? Because some people have clock genes that make them want to wake up early. Some people have clock genes that make them want to wake up late. So there are some natural variations in these genes. And then when we think about the treatment of sleep disorders, we have to change the genes. If we want to change the biological clock, we have to change how these genes are cycling through the day. And that can take time. And so fixing or treating some of these clock-related sleep disorders is not something that, to use a bad pun, can happen overnight. A little bit more about the biology of sleep or the circadian rhythm. And this cartoon of a clock is very, very helpful for me to remember because the human circadian rhythm is slightly longer than 24 hours. And basically what that means is that each day we have to spend a little bit of time setting and managing our biological clocks. Otherwise, the tendency would be for us to go to bed later and later and later each night. And we all know how chaotic that can be, but that's, for most people, the natural tendency. So what are some of the things that can be used and that we use sort of not necessarily habitually, but we learn to use throughout our lives? We learn to use light, physical activity, and then melatonin is a substance in our brains that are the main timekeepers in the body. And so these are things that you've probably heard about. We want a cool, dark, and quiet environment prior to bed because light is stimulating. We want to manage our physical activity because it's hard to exercise and then to fall asleep immediately. And some people use extra melatonin as a sleep aid, and that's something that we can talk about in the QA if needed a little bit later, but that's where melatonin comes from. It's a substance in the brain that helps to govern our biological clock as well. Importantly, these time givers or time keepers can work to favor or oppose sleep. So if you're exposed to light at the wrong time, if you do physical activity at the wrong time, it can mess up your biological clock and make it difficult to fall asleep when you want to. Now, the easiest of the circadian rhythm sleep disorders to think about when the clock gets out of sync with our daily needs is jet lag. When you fly, none of us are really flying these days, but when we used to go on trips and we would fly across time zones, our biological clock would take some time to catch up. And that's because, again, the genes that I alluded to that time the clock take a little bit of time to reset. Now, if you read more about sleep, you might read about process C, and that just simply is the circadian rhythm. Now, the sleep drive is a little bit simpler, and the sleep drive basically says if you've been up for a really long time, the sleep drive is going to build up in your body. It's very, very easy to envision that. If you try to stay up for 24 hours, the drive to sleep is going to be very, very strong. But what about somebody who stays sleepy even after a supposed good night's sleep? And this is where we talk about the intrinsic sleep disorders. When there is an abnormality of sleep, this system is never reset. And so an individual remains sleepy. And so some of the sleepiness that people with PWS experience just has to do with an abnormality of the wiring of sleep, if you will. Now, obviously, if you don't give yourself enough time to sleep and you restrict your sleep, then you're going to be sleepy as well. And that's a simple concept that all of us in a busy life struggle with. And that results in probably the most common cause of sleepiness for those of us with busy lives and not enough time to sleep. A couple more concepts to get through. The first of these is sleep disordered breathing. And so when we think about sleep disordered breathing, these are the three key indicators that we think about: central sleep apnea, obstructive sleep apnea, and hypoventilation. So to take it one step at a time, central sleep apnea occurs because the signal from the brain to the muscles never happens. And so the muscles don't fire and a breath does not occur. This pause in breathing is long enough to cause a disturbance. And these disturbances are things that we can measure when we do sleep testing. Disturbances usually mean a drop in the oxygen level, an arousal in the brain, or a drop in the heart rate. And so key factors in central sleep apnea include brain regulation and maturity. So young babies, because the brain hasn't matured, are at higher risk of central sleep apnea. That's all I mean by that. Obstructive sleep apnea means that there is an effort to breathe, but the airway is either not open or not open enough to allow for enough airflow. And this decrease or limitation of airflow causes a disturbance. And so the disturbance may be, again, a drop in oxygen level or an arousal. And again, these are things that we can measure when we do sleep testing. When we think about obstructive sleep apnea, airway size, airway shape, and muscle tone are key factors there. Hypoventilation is another one of those long medical words. And basically what this means is that there's a signal to breathe, there's effort to breathe, but one or both of these is not enough. And so that results in a disturbance. And again, the disturbance may be a drop in the oxygen level or an arousal. And so if you think about that, muscle tone and body habitus or obesity are going to be key factors in hypoventilation. So let's take a look a little bit more closely at some of the examples that can occur across the childhood of anybody, but certainly somebody with PWS. So if there are neurodevelopmental differences in brain maturity, that can result in central sleep apnea. If there's low muscle tone, which is very, very common, particularly in infancy with PWS, that can result in really any kind of sleep disorder breathing, but hypoventilation or shallow breathing most commonly. If you have poor feeding with the need for a nasogastric tube, a feeding tube that goes in through the nose, and you're an infant and half of your nose is blocked off, that can increase the risk for both obstructive sleep apnea and hypoventilation. All children experience increased growth of tonsils and adenoid tissue during usually the preschool years, and that increases the risk of obstructive sleep apnea. And that's thought to be linked as well to the initiation of human growth hormone therapy, which may also be an increased risk for obstructive sleep apnea. Viral infections in somebody with a small airway or low muscle tone can cause disordered breathing during sleep or obstructive sleep apnea. And then obesity is a major risk factor for both obstructive sleep apnea and, as I already mentioned, shallow breathing or hypoventilation. Okay, to tuck away from sleep and breathing, let's talk about how sleep is regulated in the brain by neurotransmitters. So I already talked to you a little bit about the sleep drive, which is very straightforward. It just builds up throughout the day. And the circadian rhythm, which is the biological clock. But if we look a little bit more deeply in the brain, sleep is controlled by chemical substances called neurotransmitters. And again, that's a fancy word for a chemical substance that has an action on a brain cell. And if you look at this list, none of these names are really that important for the purposes of this lecture, but you can see that there are many more wake-promoting neurotransmitters than there are sleep-promoting neurotransmitters. And the substances that I have in the parentheses there aren't even really neurotransmitters in the true sense of the word. So there's really only one sleep-promoting neurotransmitter, if you will. But you can imagine why that is, because it's important for us to stay awake. And so these wake-promoting substances have more redundancy than sleep-promoting neurotransmitters, if you will. Adenosine is acted upon when we have a cup of coffee. And I already alluded to melatonin being, it's really a hormone that helps to govern the biological clock. And it really is the biological signal for the coming of night. Now, alterations in neurological sleep regulation occur very, very commonly in conditions associated with changes in brain chemistry, because the things that result from the change in brain chemistry result from changes in neurotransmitters in the brain. And so anxiety, depression, attention deficit hyperactivity disorder all result from imbalance, mostly in wake-promoting substances in the brain. And each of these things can be associated, therefore, with abnormal wakefulness or insomnia. Similarly, the treatment or side effects of treatments can also be associated with changes in brain chemistry. And so some common medications that are used here can also cause changes in levels of wake or sleep promoting neurotransmitters and have important effects on sleep. And some examples are listed for you there on the slide. Now, to dig a little bit deeper into sleepiness and narcolepsy in people with PWS, it's such a key component of PWS that it's important to spend a little bit of extra time. As I mentioned, in some studies, the report of sleepiness can be universal in people with PWS. And sleepiness can present in different ways, and that's where sleep evaluation or a discussion about sleep with your doctors can be important. So it's easy to discern obvious sleepiness, right? Falling asleep at unusual times and in unusual places. But some of the more subtle changes that may be associated with sleepiness just simply involve changes in performance, changes in behavior. And in children, sometimes sleepiness can actually present as overactivity, including impulsivity and increased movements as children are trying to stay awake. We can test very accurately for excessive sleepiness by doing sleep testing. So the same sleep testing that we might do to learn about sleep and breathing can give us information about sleep quality, sleep quantity, and sleepiness. And then sometimes we do additional testing to really quantify whether somebody is truly abnormally sleepy or whether they even have narcolepsy. So why might people with PWS have excessive sleepiness and even narcolepsy? Well, one theory is that it's related to brain dysfunction, hypothalamic dysfunction. And the hypothalamus is a structure in the brain that is a critical switching or relay center for sleep-wake regulation and appetite and satiety regulation. And then some people living with PWS actually have a form of narcolepsy, as I mentioned before. Narcolepsy is a specific neurological sleep disorder that's caused by the deficiency or absence of one of the wake-promoting neurotransmitters called hypocretin that was on my list a few slides ago. And some children with PWS will even develop the clinical feature of narcolepsy known as cataplexy, which is the sudden loss of muscle tone, usually with laughter or other forms of excitement. Now, I have to discuss issues related to human growth hormone therapy because human growth hormone therapy has revolutionized the care and outcomes for people living with PWS. And so it requires attention to detail, for lack of a better word. So evaluation and follow-up for possible sleep disordered breathing is important in the setting of beginning this therapy. And then evaluation for growth of tonsil and adenoid tissue is important as well. And so this is a routine part of our sleep medicine practice when we see infants and children living with PWS. And so as you can see on the slide there, our practice is to see and monitor sleep and breathing in infants and children with PWS with regular clinic visits and regular sleep testing, particularly around the time of initiation of human growth hormone therapy, or if there's been a change in respiratory symptoms during sleep or performance. A couple words about the treatment of sleep disorders. And any kind of sleep disorder, the treatment starts with addressing sleep hygiene, no matter what type of sleep disorder is present. So prioritizing sleep so that sleep is not restricted, and then focusing on sleep promoting concepts that help to manage the biological clock or circadian rhythm. And so cool, dark, quiet, calm, and safe environments are important. Light is wake promoting. I already told you that. And then in order to maintain that good restful sleep, a quiet, calm, and safe environment is important. The hard part about this is consistency across a 7-day week. So consistent sleep timing is important, as is consistent timing of meals. Treatment of all sleep disorders, it sort of depends upon the context and diagnosis. For example, an infant with sleep apnea may need oxygen and clinical monitoring. A toddler with mild sleep disordered breathing may only require some allergy medications. A child with obstructive sleep apnea and enlarged tonsils may require adenotonsillectomy. And then some people with persistent sleep apnea may require positive airway pressure devices, CPAP machines, BiPAP machines, etc. People who are excessively sleepy or who have narcolepsy, there are wake-promoting medical therapies that can be prescribed in addition to sleep hygiene strategies. And then it gets very, very complex to talk about behavioral and developmental differences and their impact on sleep. So case-by-case evaluation and planning, I think, is the best way to say that simply. So to wrap up, I promise I'm almost done. Just some key points for you guys to take home from today's talk. The relationship between sleep and physical and emotional health is bidirectional, goes back and forth, and therefore the management of the health is the management of sleep, and vice versa. The management of sleep is the management of health. Second key point is that since sleep disorders, and to be honest, sleep challenges are so common in PWS, sleep quality, quantity, and respiration during sleep, or breathing during sleep, should be a routine part of conversations about health, well-being, and quality of life with the healthcare team at every visit. Third key point, many of the key clinical features that are part of PWS and its treatment increase the risk for sleep apnea and or hypoventilation. And again, whether that's low muscle tone in infancy or the initiation of human growth hormone therapy, these are important things to discuss and evaluate for if needed. Another key point involves the balance of wake and sleep promoting substances in the brain that can contribute to non-respiratory sleep problems, including both insomnia as well as excessive sleepiness. Although again, excessive sleepiness seems to be very, very common and really should be something that should be looked out for. As I said, excessive sleepiness is so common in children with PWS, symptoms should be reported to the healthcare team early and specific testing facilitated so that any treatment can be prescribed if it will help ensure quality of life and excellent outcomes. And then finally, when we think about sleep itself, sleep quality, quantity, and timing are tightly linked to important metabolic variables such as appetite, satiety, insulin resistance, and the overall risk of weight gain and obesity. And so that's my last slide. I'm going to stop sharing and go on mute now and be glad to or take any questions whenever Susan tells me to.
Thank you so much, Dr. Chidekel. We actually did have a question come in, if you wouldn't mind answering. Clearly, we need to be working with our medical professionals to treat excessive daytime sleepiness. Do you ever prescribe over-the-counter medications, or do you stick with more FDA-approved treatments?
So that's a tricky question for the pediatrician because there are limited FDA-approved options for the treatment of sleepiness in children. But we use medications that are wake promoting, FDA approved wake promoting agents for those over 18 or adults in children as we are able to. And then we use other medications as required. For example, so the stimulants that are sometimes used for the treatment of ADHD have wake promoting properties that can be used to treat sleepiness as well. Over-the-counter medications, really the only one that I can think of is melatonin, and that's more of a sleep aid rather than a treatment for excessive sleepiness. And again, I guess we could say, is caffeine really a treatment or really a medication or something, but that can be a very helpful adjunct as well for the treatment of sleepiness associated with sleep disorders, as long as side effects are not too great.
Right. And one last question. At what age do you begin considering medications for children who have excessive daytime sleepiness?
So this is something that will be individualized with the healthcare team, but we've treated excessive sleepiness and even narcolepsy in children with living with PWS as young as the early elementary school years.
Great, that's really helpful. I know we have a lot of people joining us today whose kids are right at that entry level to elementary school when perhaps, you know, behaviors that are resulting from excessive daytime sleepiness start to become more noticeable in that academic setting.
Absolutely. The transition to school is such an important time to take a step back, look at sleep and breathing, look at the timing of sleep, and make sure that there's not evidence of a nighttime sleep disorder or excessive daytime sleepiness. And if there is, to discuss it with your team so that evaluation can occur and school performance be not just facilitated, but promoted, and success really is the key outcome that we look for in our practice.
Mm-hmm. And I know I promised you the last question was the last.
That's okay.
This will be the last question. If a child in kindergarten or first grade is still requiring naps, what's your advice to the parent?
Keep the system consistent. Make sure that the nighttime sleep period is long enough, and that's sometimes a challenge with busy family life activities and school start times. But to look at that 24-hour clock, to look at the opportunity and the environment in which the child is sleeping. Think about my comfy son in the picture that I showed you, to make sure that the sleep is comfortable and peaceful. And if you have comfortable, peaceful sleep that is for a long enough duration, given the individual age of your child, and there is still excessive sleepiness during the day, then that may be a flag. And then to answer your question specifically about naps, there are some children at that age, 5 to 7, 6 to 8, who still require a nap when they come home from school. And some children with learning differences, they're working really, really hard during the school day, and they do need a nap when they come home. But it should be something that's controllable. And sleep attacks, sleeping in unusual places recurrently, is a red flag for excessive sleepiness, even in the context of a busy and rewarding childhood life.
Great. Well, thank you so much, Dr. Chidekel, for giving us some of this information. We will have you back at the end of the session for more Q&A. So if we didn't get to your questions already, people, are welcome to continue to give us some Q&A. But at this time, I would like to move into the second part of our session, which is a discussion with Cindy Szapacs, who I mentioned earlier is a caregiver to her teenage son living with PWS. Cindy's son, Dash, who remarkably looks and sounds like my own son. Facebook seems to think that they are one and the same people. But Cindy's son, Dash, experienced challenges with sleep, which ultimately led to a diagnosis of narcolepsy. So Cindy, I'd like to thank you for joining us today and sharing your experience with us. Perhaps you could give us some background on your journey with Dash and the daytime sleepiness that he has experienced.
Sure. Thanks for having me. I'm excited to talk about this. So my son falls into that category that Dr. Chidekel discussed of the not typical sleep presentation. He was never, he's 14 and a half, doesn't sleep in the car. He doesn't have the sleep attacks. Actually, when we vacation, when we go places, we pretty much always had to get like a room that was a suite, because he couldn't fall asleep unless he was alone in a dark room. And if we were staying in a hotel room where we had to share, where there's like 2 beds, it was chaos. Like he would have tantrums, he'd be throwing things. And we never considered that a sign, like we didn't know that was a sign of sleepiness to even consider. And I was like, oh, I have this kid who, he sleeps at night. He goes to bed earlier and he'd sleep longer periods. And, he napped almost up through kindergarten, but it never was like that traditional sleepiness stuff. And then trying to treat kind of that transition into kindergarten, when we wanted to treat what we thought were ADHD symptoms. And we tried some ADHD medications with the psychiatrist, and they just ramped up the anxiety. And so that didn't work. So then we tried Provigil. And all of a sudden we had this child that literally was, not perfect, he still had Prader-Willi syndrome, and he still was, 5-6-year-old, but immediately we saw this cooperation, this ability to stay up longer. Prior to that, so he was 5, and around that time we were stuck in our house from around 5:30 at night. We couldn't go anywhere. if we wanted to bring him, because his behavior was so unpredictable. And getting him to sleep, wasn't great. And then we put him on this medication that is meant for daytime sleepiness. And all of a sudden things were much better. And then we had periods through his life where we've always been the sleep study. So Dr. Chidekel is our doctor. We were lucky enough to get hooked up with him in the NICU, and initially for pulmonary stuff, and then we worked into the sleep stuff. So we've done sleep studies since birth. I don't know, we've probably done 20 at this point. And through the years, we, monitored those studies as well, and did a couple of the nap studies when we did start seeing. So in first grade, and then again in fourth grade, he was falling asleep at school. And so we saw a little bit of that as he got older, and he was on the Provigil. He was falling asleep at school. And then that's how we got that narcolepsy diagnosis. We did the daytime nap studies and the nighttime studies. And so we kind of ended up through this non-traditional route.
Right. So you noticed these, that, he wasn't, you weren't able to take him out in the evenings because apparently he was tired. How did you ultimately make that determination of, he's tired and therefore we should try Provigil? So
we tried the Provigil to address the impulsive behavior. So it wasn't even, we did it through the psychiatrist. It's not FDA approved for ADHD, but there's some minimal research that it could maybe be helpful. And so we kind of used it, that was our last ditch effort, because the actual ADHD drugs we tried made his anxiety just horrible. He couldn't tolerate them. And then over time, backtracking, we're trying a drug that treats sleepiness, and now we're getting an increase in cooperation. He's happier, some of the other things. And so it's kind of been a slow journey as he's gotten older, because he wouldn't nap. Like we'd say, just go to sleep then. And we actually had to do like behavioral protocols and rewards to get him to accept naps. But when we did, his entire life changed. So that was in like 5th grade. Things were not good. And we started being able to get him to take naps on the weekends. And so he would take a nap and then he would wake up as like a completely different person. I mean, his mood, his cooperation, his everything, his face, like everything just was better. And we were like, okay, we've got a sleep thing going on here. Now that he's cooperative enough and he's learning, some of those coping skills, and he's advocating and taking naps. So as he started being willing to take more naps, and then we were able to see that life was a little better and easier for him, his behavior was better. That's kind of how we put the 2 and 2 together.
So he wouldn't have taken a nap on his own. You reinforced that behavior and saw these tremendous benefits for him.
Yeah.
That's so interesting. And so then what led you to pursue a narcolepsy diagnosis for him? He wasn't falling asleep during the daytime. What would have led you to believe that might be the case?
So truthfully, we had been following the pitolisant study from the very, 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 very beginnings. And we're interested in that, being able to access that drug. And the only way to access that drug is with a narcolepsy diagnosis. And some of his symptoms that we were seeing during the day, with this needing to sleep and this extra sleep, were indicative of that. And so when we had his next sleep study, we scheduled the sleep with the nap study and did the nap study. And lo and behold, he met the criteria for narcolepsy.
Mm-hmm. So you've mentioned that you tried Provigil and you got some benefit from Provigil, but you were still interested in trying something else. Why was that the case?
So Provigil was helpful and it was better, but he was still, requiring naps almost daily, and nighttime could still be a little dicey. It had gotten better. Historically, all of his problem behavior were occurring at night, which also led us to see let's just put 2 and 2 together. There's other factors. It doesn't really matter what's happening, if there's a demand or not, we've got these problems at night. So it seemed to be sleep related. And so it was working. He was on a really high dose. And, it can be addictive. We weren't experiencing any side effects, but it's always possible. And so when looking at the two, pitolisant seemed to be a little bit safer. And there was a possibility of some of these other benefits that some people, were reporting just anecdotally, what they were seeing. And so we felt like if you truly had narcolepsy, he also takes a variety of other medications like for anxiety and a variety of things. And it would just be really nice to not have to give him so many. And if we could get more bang from our buck from one medication, we thought, we'd give it a try. So that's how we made the switch, or kind of why we made the switch. And we have seen, and just in our instance, again, I'm not saying this is the case that every person will see, and I'm not here saying everyone should do this. Just our personal experience was that we did see some of those outside benefits from the pitolisant. We do see less sleep. We see more social behavior. We see much more rational thinking. We see better speech abilities. And like just across the board, I just say life is easier. Right. We're able to do more things as a family. Like when you have a kid that, and I'm sure you experience this too, when you have a kid that's tired and you never quite know, well, is tonight going to be the night they can make it till 9, or is tonight going to be the night where like 6 o'clock is it? Our life revolves around his sleep schedule, because if somebody's tired, you can't force them to do it. Like you just know it's going to happen. If I force it, and something not so great happens, it's my fault. It's really my fault. Like I should have known better. Right. And so we were like trapped. Like I have a 10-year-old and, he does sports. And so if we often would take 2 cars with us to have that, kind of like a getaway car, if Dash just couldn't make it. But now we take 1 car, and if he is a little bit tired, he's compliant enough and he's just like, I'll just sleep here. And so we did a lot of baseball games this summer, where he either was hanging out with flirting with the moms and talking to the little kids, or now I'm going to go sit down and take a little nap in the chair. So we're able to do more things, the 4 of us, instead of having to split into 2 and 2.
Right. So just to clarify, you have participated in the pitolisant clinical trial, the phase 2 trial, which is ongoing, because you can't get pitolisant for PWS unless you're in that trial.
Correct.
Right. And during the course of that trial, have you seen increased benefits over prior when you were using the Provigil?
Yes. And we did, and we have seen, as we are in the open label and have increased dosage, kind of some side effects that we didn't want. And so we're playing around, and we found to go back a little bit. And we're much better now than we were like a month ago when it was a little bit higher. Mm-hmm. And we did the washout period for actually 6 weeks. So we took him off of everything for 6 weeks, and he had been on he'd been on like the Provigil since he was 5. And so for about 9 years, and he had been on something, and we went 6 weeks without it. And I was like, oh man, I don't know. I'm not sure what's going to happen here. Like I was ready to call like just half a school day, like whatever we needed to do, because there's so few treatments for this. And we were kind of at that desperate point. Like we had one that was pretty successful, and we had modified our life to make things work. And we kind of were just going with where we were and making sacrifices. But then it got to the point where we just decided it was for us, it was worth the possible sacrifice and the possible risk of 6 weeks, and then an additional complete trial of being on placebo to get to the pot of gold at the end of the rainbow, which was the open label. And so, but those 6 weeks really, I mean, one day he slept 5 hours during the day and came home and went to bed at 6:30. Like there's a sleep issue there.
So it doesn't get any more clear than that. He
Right.
had excessive sleepiness. The modafinil did help him. I can only imagine the wild ride, though, that you had to go through to wash him out before you could start the study. Any regrets there?
No, actually, I'm actually really glad we did it, because in hindsight, it really confirms, the sleep issues. His school is we could not have done it without his teachers. They're amazing, the school he goes to. I worked with them beforehand. So I warned them, I said, this is what we're doing. This is why we're doing it. He has it in his IEP that he's allowed to take a nap. But like Dr. Chidekel said, we limit it to 30 minutes. We don't let it go too long. And we just said all holds, everything's off at this point. However many naps he needs and however long he needs to sleep. And then if his behavior is such that it's not safe or we can't keep him at school, let's convene and we'll change his IEP. We'll do a half a day, you know. And the bus people were great. He drives an hour each way to school in a van. It's just him, luckily, and a fabulous assistant. So we had a lot of help. And it was really like the last 2 weeks that we were like, oh, because we saw, like, when he is tired, the food seeking. Well, he isn't a food seeker per se, but the asking for food, wanting more, talking about food, that just, when he's tired, that's it. It's all about the food. The nail biting and picking. He had, like, the lips. He'll bite his pick his lips raw. All of that goes up big time when he's tired. So that's another reason, kind of, we know if he's sick, because he's usually tired when you're sick, and all of that stuff increases.
You could be describing my own son.
Of course. This is how it always goes with the two of them.
It's so fascinating to hear the similarities, right? And, you know, I always say it's like a roller coaster with Jaden. You know, the intensity of his food related questions, it increases and decreases. And when you're in the moment, it's so hard to identify the cause. But then you look back and you start to see this pattern, and I'm hearing it with you. Like you didn't know exactly what the cause was, but once you identified it, it all became clear. I'd love to hear more from you. I mean, you've clearly worked extensively with your school team to support Dash and his needs. What based on what you've learned in your experience, what would you recommend to others who are struggling with daytime sleepiness? How can they work with their school team on this?
So initially, we started this journey with a different school team, and his behaviors related to excessive daytime sleepiness helped get him into a very nice private school, or a private type of a private school. And so initially I worked with the team and I just said, listen, we got the study. Dr. Chidekel had a letter written that he has narcolepsy, he has sleep apnea, and he needs naps during the day. And just to help them understand that. And that took some time, honestly. There was a lot of rules in place for, they weren't giving him naps until we had the doctor's note. But of course, to get a note, it takes a little bit of time. And so in the meantime, things weren't so great at school until that note came, even though I was telling them, this is what you need to do. So I just stayed, I just advocated, just be upfront, this is what it is, have the note from the doctor. And then it'll depend a little bit, I think, on the receiving team, how flexible they want to be, how willing they are, the type of space they have. Like I said, the next team that we transitioned to was very, I think they were a little bit more familiar as well. They deal a little bit more with a population that requires the naps and that type of thing. And, they were great about it. And, from the get-go, I just always, and my motto was always just to share everything. Whatever a doctor tells me or whatever, whatever someone, I just tell the school to be upfront about it, so they know, and then we can work together.
Right. I would like to encourage everyone who's on the line with us today, if you have questions for Cindy or Dr. Chidekel, you're welcome to put them into the Q&A. We will go into open Q&A here in just a second. Just to note, we can't answer questions about personalized dosing for your child or medications. And also remember, Cindy is just like us, a mom to a loved one with PWS, but neither she nor I are medical professionals. We cannot advise you on what to do. We can only share our experiences, but we are happy to do so. Again, if you want to put any questions into the Q&A, you can. Cindy, any final thoughts? If you had any advice to give parents who are on the line today and who are maybe struggling with daytime sleepiness, or maybe they're struggling and they don't know it's because of daytime sleepiness, what would you want to tell them?
I mean, after this experience, when a lot of people remark on a sudden change in behavior, even if it's not associated with excessive sleepiness, like falling asleep, I always ask, have you had a sleep study recently? Have you considered a nighttime study? Before, you want to obviously try, if there's behavior interventions and things like that, but throw that into the mix, because that's going to be really, really important. Because if that is there, if that fatigue, if that sleepiness is an issue, it doesn't matter how good your behavior interventions are, they're not going to work. It's just going to keep getting worse. And so I would say just, if you can't put your finger on it, or the behaviors are changing, or you're just seeing, like you had said, like more of this anxiety stuff, and what as anxiety is in your kid, when things are different, you just get a sleep study.
Yeah, I mean, I think that that's a great recommendation. And I'll add to that as well, because we've had lots of challenges with behavior, anxiety, and sleepiness. Build a relationship very early on with your medical team, including your sleep doctor and a psychiatrist. A psychiatrist will be the individual who will prescribe the medication. So if you have daytime sleepiness and you want to try Provigil, you need a psychiatrist to do that. If you're struggling with anxiety and ADHD type behaviors, which could also be sleep related, again, the psychiatrist is likely going to be you're the person who works with you to prescribe and will follow you in your case. So make sure that you're building those relationships with those folks. And at this time, Dr. Chidekel, if you're still in the back, we'd like for you to come back and join us, because we do have a couple of questions for both you and Cindy. The first one coming in is about sleep elicited narcolepsy, or food elicited narcolepsy. Many of us have experienced or know others who have had children who, while they're eating, they just drop, they fall asleep in their plate. It's not as cute as the neurotypical child with the meatballs and the spaghetti, like it happens frequently. Do you have, first of all, what's your experience with food elicited narcolepsy? And is there something that the parents can be doing about this at a young age?
So in full disclosure, I can see the Q&A. So I'm gonna speak a little bit more generally, and then please go back, Susan, and read any of the specific questions that that requires that. I think I'll say a word about sleep testing, because I didn't have a slide on. I guess that was something I should have added. Usually the sleep testing starts with something called an overnight polysomnogram. Polysomnogram is, again, it's just another one of those fancy words. We measure a lot of things about sleep and breathing and brainwave activity to ensure that the sleep architecture and quality are normal, and that respiration during sleep is normal as well. Cindy alluded to sleep disordered breathing and sleep apnea. Sleep apnea can go hand in hand with a diagnosis of narcolepsy or a behavioral sleep disorder. So just because you have one doesn't mean you don't have to have another. And the challenge with respect to that is you have to treat all of them. And so the overnight sleep study is usually the first step. But then again, as Cindy alluded to, when we are concerned about daytime sleepiness, the person, the child, the patient will stay in the sleep lab during the day and be given the opportunity to nap at regular intervals throughout the day following the overnight test. And, the way that I think about this with typically developing teens who come in and complain of sleepiness or fatigue, I say, okay, we're going to give you the opportunity to fall asleep every 2 hours during the day. And somebody who is sleepy will be able to do that, but somebody who is not truly sleepy, somebody with fatigue or low energy, if you will not be able to fall asleep on command every 2 hours. And then the diagnosis of narcolepsy is confirmed when you have dream sleep during those daytime naps. There's some subtlety there, but we don't need to quibble about that. But so anyway, the diagnosis of a sleep disorder, you start with the overnight sleep test, and you include a nap study if indicated, and if there is excessive sleepiness, you need that overnight sleep study. The symptoms of sleepiness, again, I tried to break it out in the presentation into those which are kind of easy to see and those which are not so easy to see. Cindy did such a fabulous job describing how sleep can just dysregulate behavior, and you really need to be suspicious that if the behavior is just not right or is changed or is different, then think about sleep as well. I see a related question quickly in the chat. People whose child had a sleep study, whether it's at home or clinic-based sleep study, it's not recommended in children to do at-home sleep testing. The simple reason for that is children are smarter than adults and they will take the sensors off all night long. And so home sleep testing is not something that's done in children, and people with PWS are too complicated. They should have in-lab testing done anyway. There's some questions about, again, sort of age and starting medications, and boy, we individualize things, particularly in young children. It's not because the medications are so crazy and unsafe, et cetera. It's just, you just need to be careful about using them for specific purposes so that the medicine is giving you the outcome that you're looking for. So for example, if you're using a medication to try and target sleepiness, but as Cindy mentioned, you get increased anxiety, you need to make sure that you're staying on top of that with the medical team so that other things can be either discussed and or attempted. Sleep eating is very, very common in people with PWS, and I agree. It's not like when my kids would fall asleep at the dinner table, or when I was in my training and I would fall asleep at the dinner table. It's a very different thing. You might even think about it as almost a form of cataplexy, if you will. The children are excited about food, they're excited about eating, and then they have this sudden attack of cataplexy that causes a loss of muscle tone. It's subtle, it may be hard to distinguish, but cataplexy should be happening with the person being awake. It's just an awake loss of muscle tone, as opposed to true sleep eating, which is also common in people living with PWS. So there may be some subtlety there, but if that is something that an individual, really any individual, is experiencing, then going through the sleep evaluation and testing is going to be indicated. There's a question about the treatment of obstructive sleep apnea. Again, it's something that if you have big tonsils, you're not going to outgrow sleep apnea, but tonsillectomy and adenoidectomy can be a very, very effective treatment for obstructive sleep apnea. The challenge is whenever there's an underlying condition that affects the size, shape, and tone of the airway, the outcomes are going to be less than perfect. Not that we have perfect outcomes to begin with. And so that's where repeat sleep testing, as burdensome as it can be, becomes important to make sure that the airway concern, the airway issue, is being addressed at least to an acceptable level. And so that's something that is, again, important to realize. And so we may be more inclined to do repeat sleep testing in children with underlying conditions such as PWS, such as trisomy 21, et cetera. There's a question about having a clean study and no symptoms. So you're lucky, and we would just follow clinically in that case, and just be suspicious that if there is a change, even a non-specific change, sometimes sleep apnea in people with lower muscle tone does not cause the snoring and gasping and restlessness that I alluded to earlier. Some of the questions are a little bit complicated, and so I'm gonna skip over those, but I'll turn it back to you and Cindy. I don't want to dominate, and just I'll take a breather, and then I can come back in a moment.
Well, we appreciate you answering these questions because you are the reason why most people are here today. They really do have questions about sleep. Just for the record, you are at Nemours Hospital, and do you accept new patients?
I'm in Wilmington, Delaware at DuPont Hospital for Children. Cindy knows how to get in touch with me for sure, and so do you. So you can feel free to give out my contact information. That's no problem. That's no problem at all.
Well, thank you.
Can I make a quick comment? I was just thinking about kind of what Dr. Chidekel was saying. We were kind of that situation where Dash's sleep studies weren't really bad in the beginning, but we started at basically when he started growth hormone at 5 weeks old. But we still did them every year. At one point, we were every other year, but every 4 or 5 years, it would be not a great one. And so then we'd have to go and talk about treatments and try the BiPAP. He did have his tonsils and adenoids removed when he was 7. We had a couple years of success with that. And then again, repeat studies, we found this obstructive sleep apnea, which, like Dr. Chidekel said, is probably just because of the floppiness. There's no tonsils there anymore. And then we found the narcolepsy. So I know some people say, well, my kid had, a good study 4 years ago, and I would still say, go again. Just, you never know. Because we saw a lot in our experience. Even we had some good ones and we had some bad ones, and we saw a lot of change through the years.
Yeah, our kids are complicated and they're constantly changing. So we need to do that. We're going to take one last question. Which one will it be? Can kids have seizures in their sleep? And what are the symptoms that would be cause for concern?
So nighttime seizures can absolutely occur. Seizures can occur during sleep. Oftentimes there will be atypical movements, and so concerning movements can be videotaped now and brought to the appointments. And boy, that's something that it makes it a lot easier for us as well as for families. And so any strange behaviors during sleep, and then occasionally if we're suspicious about nighttime seizures, we work with our neurology team. We can do a full EEG during the sleep study. Usually sleep studies have just a few EEG leads that do sleep staging rather than looking for seizures, but that can be done that way as well. There's one question about sort of sleep hygiene that I think can be very, very helpful. As I mentioned in the slides, there are things that can help promote sleep when you think about sleep hygiene, and then there are things that can work against sleep. And so as a general rule, we talk about an evening wind down period. We talk about cool, dark, quiet, calm, and relaxed. But the specific question is about a person who has trouble staying awake after dinner, and that's common in the elderly as well. And so usually what is recommended for those sorts of advanced sleep problems, or in this case, sleeping for a while and then not being able to go back to sleep, is as much light and stimulation as possible after dinner during that at-risk period, so that the wake promoting stimuli can hopefully head off that nap, which is coming at a very inopportune time. Getting out for some exercise could be another strategy, but those are the things that you can try to work with to see if you can avoid that difficult lull after dinner.
Dr. Chidekel, Cindy, thank you so much for joining us today and sharing all of this wonderful information. I would just like to ask everyone to please mark their calendars for next year. We are planning to be in Chicago, September 29th through October 1st. And we would, of course, love to see you in person for our first in-person conference in 2 years. And last but not least, Cindy had mentioned it earlier. She has participated in a phase 2 study for pitolisant. which is for excessive daytime sleepiness in PWS. So I'd like to show you all just a brief video that tells you a little bit about that study, should you be interested in learning more. So have a wonderful rest of your day. And here is a short video from Harmony Biosciences.
If you or someone you love has Prader-Willi syndrome, you may be interested in a clinical trial open to people with PWS who are between the ages of 6 and 65. This trial will study the safety and effectiveness of an investigational medication and its impact on excessive daytime sleepiness, behavioral symptoms, and cognitive function. Clinics across the United States are currently enrolling participants, with more sites being added, and travel expenses to the clinic most convenient to you will be paid for by Harmony Biosciences. So, what's involved? Well, that depends on whether you are the person with PWS or the caregiver. If you plan to participate, there will be 5 scheduled visits over the course of about 4 months. And if you're a caregiver, you'll accompany the person with PWS to each of the visits. For caregivers, your support and participation will be important. For example, the first visit involves an initial screening and the start of a 2-week sleep diary. Making sure the diary is kept up to date will be the responsibility of the caregiver. The second visit includes nighttime and daytime sleep tests to confirm that the person with PWS is eligible for the trial. If eligible, the person with PWS will start taking their assigned study drug once daily in the morning after waking up. This could be the investigational medication or placebo. The dose will be kept in a diary, updated daily. Making sure the diary is kept up to date will be the responsibility of the caregiver. The next 2 visits are to assess how the person with PWS is progressing. At the last visit, the nighttime and daytime sleep tests will be given again, and then it's time to consider whether to continue into the long-term safety trial, where people with PWS will take the investigational medication and help researchers collect information. There will be no placebo during the long-term safety trial. Clinical trials are essential for the development of new treatments to potentially help people living with PWS. And every clinical trial starts with volunteers like you. To learn more about this trial, you can contact Harmony Biosciences at clinicaltrials@harmonybiosciences.com.